Welcome to EHJ Today. I'm William Wijns from Belgium, and joining Professor Kimura from Kyoto University, Japan, and Professor Steen Kristensen from Aarhus University, Denmark. We will discuss the results of Absorb Japan, a trial comparing bioresorbable scaffolds with metallic stents. So, Dr. Kimura, why did you decide to perform this trial in Japan?
Yeah, actually, there is a couple of randomized trials comparing BVS versus current generation metallic drug-eluting stents. However, we have to get the approval of these new devices, so the Absorb Japan was conducted to support the regulatory approval of the BVS in Japan.
So that's a good reason to perform the study. Is there any additional learnings that we could expect from performing this trial in patients in Japan?
Basically, our finding is very consistent with the previous studies, such as Absorb 2. We did show the non-inferiority of the BVS relative to EES in terms of the clinical endpoint of 12 months TLF, and also the angiographic finding is very consistent. We didn't find any difference in terms of the binary restenosis percent DS at follow-up. Also, we saw 1.5% stent scaffolds thrombosis in both groups. So by doing many relatively modest-sized trials, we could get some information regarding the very low frequency event, but important events such as stent thrombosis by pooling these data. Yeah.
That's interesting. Now, for colleagues who may not be interventional cardiologists, just remind us in a few words the design of the study, your hypothesis, as well as the type of patients that were enrolled.
Type of patients enrolled is the typical patients for the pivotal studies for drug-eluting stents for approval. So relatively simple patients, simple non-complex lesion.
So what was the primary endpoint? It was a non-inferiority design?
It's a non-inferiority design. The primary endpoint is 12 months target lesion failure, a clinical endpoint, and secondary endpoint is 13 months angiographic late lumen loss.
And the study did reach its primary hypothesis
both
endpoint?
primary endpoint.
Great. So how will this be perceived by the colleagues in Japan in terms of the performance of these bioresorbable scaffolds versus metallic stents?
Yeah, for this type of relatively simple lesion, BVS perform equally well in terms of the 1-year clinical endpoint as well as angiographic endpoint. But we have to look carefully about the scaffold stent thrombosis by looking at the more data for this endpoint.
Perhaps in more complex patients as well.
Also,
yeah.
also.
Thank you. If you agree, I'll turn to Dr. Steen Kristensen. And Steen, what did you think of the results of this study?
Well, I think that Dr. Kimura and colleagues have done a very well-conducted trial with all the patients. No patients were lost for follow-up. And I think also it is relevant really to do studies with the new bioresorbable stents or scaffolds comparing to the stents that we are using at the time to really get an idea if there's any difference at 1 year. The key thing, of course, is if there's something coming long-term where one maybe could expect that the bioresorbable scaffolds or stent could be an advantage. I mean, we don't know yet, but that's the hypothesis that we hope it would be, because we know also with the stents that we are using presently, although the stents are very good and maybe be difficult to beat in terms of acute phase, there are probably some problems in a few patients later on.
So you see this as a great opportunity to improve the outcomes long term?
Yeah, that's how I see the new scaffolds.
Now, you mentioned about stent thrombosis. There have been some reports on relatively high rates of stent thrombosis early on, but then it turned out that these were probably related to procedural technique. Can you say something about the procedural technique implanting those devices? Is it more difficult than regular metallic stents?
Regarding the device and the procedure success, the success rate was very high in both groups and not different between the two groups. But we did 80% post-dilatation at 15 atmospheres. So procedurally, we did a fairly good performance. But despite that, the final in-device MLD is slightly but significantly smaller with BVS. And also the BVS strut thickness is a little bit thicker than the metallic DES. So these things may contribute to somewhat higher incidence of relatively early stent scaffold thrombosis.
Now, Japanese colleagues are known to be extremely careful about their procedures, like we all are, but also extremely experienced, and also they use a lot of imaging. Mm-hmm. Was invasive imaging used in this trial?
In this trial, we also randomized patients to post-imaging group versus no post-imaging group. But the post-procedural imaging did not affect the in-device MLD, both at the baseline and the 13 months follow-up, because we are somewhat concerned about the fracture of the strut by over-stretching the scaffold. So we have to make much more effort to optimize the expansion of the scaffold.
Correct, and that was achieved by a relatively high rate of in-stent or in-scaffold post-dilatation. You said 80%, 80, yeah. Steen, how do you see the dual antiplatelet therapy issue, so to speak, with bioresorbable scaffolds versus metallic stents?
I think, first of all, we do not really have randomized studies. We have planned or have simply used what we've been doing with the other stents, being a bit careful. I think most would give dual antiplatelet therapy, and since we are now using these stents in elective stenting, we would usually use aspirin and clopidogrel for 12 months. I think that's what most doctors would do that are practicing with the new devices.
Is that what was recommended and also done in the trial, that dual antiplatelet therapy was stopped at 1 year?
No, actually the protocol dictated 1 year DAPT, and the patients and physicians are very compliant. At 12 months, 97% of the BVS group were still continuing DAPT, but probably even after 1 year, many Japanese physicians will continue the APT, as is the case with the metallic DS still.
Mm-hmm. Now, do you think this treatment will have to be continued until the scaffold dissolves completely?
I'm not sure at this point. We should look at the very big data, even observational, comparing the duration of the DAPT versus outcome.
So what you're saying is that we don't know yet, but in a patient with low bleeding risk, it might be wise to actually continue. Is that a fair statement, Steen?
It's fair, and I think also so far we have mainly used the scaffolds in patients that have a fairly low risk, and this also goes for this trial. Some of the more severe patients, with low ejection fraction and poor renal function were not included in the study. So I think that for the patients that we now are using the new devices, they are probably not in general very high bleeding risk.
So to conclude this exchange, thank you very much. Dr. Kimura, would you like to summarize in one statement what you like our colleagues to remember from the study Absorb Japan?
Mm-hmm. In terms of the 1 year clinical and angiographic outcome, we could say that the BVS is comparable to current generation metallic DES in relatively simple region.
Thank you. And Steen, how do you see the contribution of this trial in our overall knowledge?
I think this is one more piece to the jigsaw puzzle. I mean, there are several trials that are coming up in various scenarios, and I think that Absorb Japan is pretty much online with, for example, the Absorb 2, and I think that's encouraging.
Yeah, I'd like to say that thank you very much. I mean, this trial is published today in the European Heart Journal. It is high quality, very well done, and as you said, Dr. Kimura, we will be able to pool these data with the similarly high quality acquired data on Absorb and learn more as we gain experience and knowledge with the use of these devices. Thank you very much. Both.
Thank you very much.
Well, thank you.